it all is. And nearly 1 of every 10 persons aged 18 years and above has raised blood glucose levels. And we are the capital of diabetes. So it's good that we are really addressing this on a big major way. And every 4th individual in India above 18 has high blood pressure, so it's increased by 10%. Just to put the statistics a little, and the prevalence of current tobacco smoking has declined, but still quite high. And more than 2/3 of adolescents are only active at about 1/3, and the level of physical activity among adults is only 13%. So you can imagine the big problems that we have today. So over to you, Madhu, to take this forward. Can we have the slides, please, of the speakers? It's a great, absolute pleasure and privilege, Madhu, introducing you, a great friend, and it's great to see you here virtually and looking forward to meeting you there in Goa. So we all know her. She's a consultant, Diet for Life Clinic at Panchkula, former senior dietitian from PGI Chandigarh. Lots of awards to her credit, is a life member of many associations, has been associated for almost 3 decades with pediatric nutrition. So anything with pediatrics, we know where to go to for guidance and advice. Has authored 3 books on pediatrics nutrition. And we've got a very august gathering of panelists. Can we have the panelists too, please? Madhu, would you introduce them?
Okay.
Yeah.
Can I get the panelists? Okay. Anita, thank you very much, first of all, for that kind introduction. And at the outset, I would also like to thank the organizing team of DAY and Cheryl in particular for giving me this opportunity to be a part of this important, very prestigious event. I'm really honored. Now, metabolics. Now, do I introduce the panelists?
Yeah, I think, Madhu, yeah.
I'll need the slides. Can I get the slides of all the panelists, please? We have a very expert set of 4 panelists with us, and I'm sure they're going to do a lot of, justice to a lot of the questions that we'll be dealing with and enlighten us more further.
Yeah, I think everybody can put their videos on. Yeah.
So may I have this first slide, please, of the panelist?
Aritra, Dr. Geeta, hi.
Geeta, Aritra Khan, and Shweta, Anaga.
Are we sharing the slides?
I think we can start. I'm not able to reach them. So
okay.
We'll start.
Okay, yeah. So I think we know everybody. Please, Madhu.
Yeah, okay. So we know Dr. Geeta Dharmati from Pune. She's an expert on nutrition as such, and she has a lot of credit to her publications also, and she's doing a lot of work on cell metabolism. And then we have Dr. Aritra Khan from Mumbai. I think I'm not too sure about his thing, so I think he can introduce himself later. And we have Shweta Batta, who's from Ludhiana, another very good dietitian and nutritionist from DMC Ludhiana. So without wasting much more time, I'll just give a brief intro of what the topic of the theme is. It is on metabolic syndrome, as you all know. And metabolic syndrome now has become a part of almost all the illnesses we come across. And it has steadily crept into the lives of all humans globally. And the degrees may vary from region to region. And it was originally considered to be the home, the home of the bane of invasion of the Western culture by way of great industrial revolution, which happened way back in the 60s, later 70s, on that time. And over time, it was all over the place, including all of the Southeast Asian regions, and India too was not spared, especially the food industry, which has primarily influenced the Indian palate also. Now, coming back to the metabolic syndrome, all of you in this august audience are well aware of what it comprises. In short, like obesity, the central obesity, especially where the waist-hip ratio is the main factor. There's impaired fasting blood sugar, where insulin resistance is involved. There are deranged liver functions and MAFLD or NAFLD, which was called non-alcoholic fatty liver disease earlier because of alcohol. It was it was called, but later on, because it's now known that it is no more a disease of the alcohol, but it is a metabolically associated disease, so it is called MAFLD. And as clinical nutritionists and dietitians, all of you must be thronged with patients walking in with similar problems. And this is what brings us to ponder over why there is such a pandemic of this entity called metabolic syndrome. So friends, that is what we would deep dive into this session. And our esteemed panelists here, they will revolve around this conversation by we'll revolve this conversation on by a case study, through a case study which I'll just present, and we'll dwell on the management and ultimately the reversal, if possible, and prevention of metabolic syndrome. So shall I just share the screen? One second, how do I share the screen?
There's a green button down. Madhu, nature.
Ma'am, are you able to share screen?
Yeah, can you see it?
No, I think it will come.
Geeta, can you just share it, please? There's some problem I'm facing.
Do you have the permission to share the screen, ma'am? Or should we ask the admin?
Okay, Geeta could share it. Thank you, Geeta.
No.
Geeta, put on slideshow mode.
Can you? I can't see the slide. Yes. Is it visible?
Yeah.
Yeah. So this is a case we have with us today. This is a patient who is a 32-year-old male, and you can see his BMI is 32 kgs per meter squared. His fat percentage is 32%, and his waist circumference is 124 centimeters, which makes him obviously obese. Then his labs, which tell us a story of his A1C being 6.5%, his fasting sugar is 120 milligrams per deciliter, and postprandial is 180 milligrams per deciliter. And deranged liver enzymes, though the figures are not mentioned here, but it says the raised enzymes, SGOT, PKF, both are raised, and hyperuricemia also. And his ultrasonic reports show us MAFLD, and along with gastritis. From the history, whatever we know is that he complains of inactivity. He's fatigued all the time, lethargy, disinterested in work. His lifestyle, basically, what we can see here is not appropriate. And then another big factor is that he probably would be some corporate person, or his job is such that he almost 15 days in a month he's traveling off and on probably. So obviously his activity is reduced. He's more of a sedentary work. Then the poor sleep pattern may be there because of erratic timings and traveling and various shift of places. And then one more thing that we know is that he's a strict vegetarian, and he has recently gained weight, almost about 10 kg in 6 months. So what do we have here? The diagnosis based on the parameters, what we can see is that obviously he's overweight, obese, in fact, pre-diabetic, he has MAFLD, and he has a faulty lifestyle. So now we come to the questions. So I'll come to the panelists. So this is, I'll just keep this case presentation over here. And I think I'll just go to Anaga first. Anaga, when you see this patient, what comes to your mind? What your approach would be? Are you satisfied with the the history that is in front of you, or would you like to know something more about this patient and why?
Good evening, everyone. So this is typically a case of metabolic syndrome, as ma'am has presented the features, and I would like to do a detailed nutrition assessment of this individual And yes, I can see some of the nutrition assessment basically comprises of A, B, C, D. There is anthropometry, clinical, biochemical parameters. Some of them I can see over here. I would directly go to the diet history of this patient in order to make it quicker as well. So as far as the diet history is concerned, I would like to know what are his food preferences. Now we know he's a vegetarian. I would like to take a detailed 24-hour diet recall of the day that of the food intake on the days that he's traveling and the day that which he is at home, and what exactly is his routine all about. Whether he's traveling, what is the access to food that he has, whether he's eating all outside food, whether he has special arrangements for him, or the food prepared is healthy choices, or he has to eat whatever is served to him. Even at home, what are the food facilities that he has? Apart from that, after a 24-hour diet recall, I would like to figure out certain calculations of macronutrients and calories, because of course he is an obese individual. So I would like to know what is his calorie intake, and also what is the calorie intake coming from the empty calories or food that he eats from outside, or the processed foods that he's taking. Now, carbohydrate is supposed to be one of the major macronutrient associated with metabolic syndrome. So here I would like to know what is the total intake of carbohydrate, the quantity as well as quality, how much percent of carbohydrate, because we Indian tend to have really high percentage of carbohydrate in our diet. Apart from that, what is the intake of dietary fiber? And as we know, fructose and typically foods which are rich in fructose, such as sucrose or sugar-sweetened beverages, or foods which are ultra-processed foods or confectionaries, are also linked with metabolic syndrome or features of metabolic syndrome, such as hypertriglyceridemia or central obesity. So I would like to know what is the intake of sugar as well as honey, jaggery, and fructose-rich foods. Is he being consuming them? Because if he's a corporate individual and especially a non-alcoholic, there is a possibility he might be having a lot of juices and other beverages which contain a lot of fructose. So just checking that. Proteins, what is the source? If he's a North Indian, there is a possibility he might be eating paneer or dairy products a lot. So fat intake, or what is total protein intake? And at the same time, presence of organ meat, red meat, would like to check that. As far as fat is concerned, would like to know the type of fat, the typically the cooking oil, whether the fatty acid profile of the oil, whether it is MUFA or omega-3, omega-6 based. Omega-3 intake. At the same time, through food frequency, I would like to find out the intake of foods which are rich in trans fatty acid and saturated fatty acids. Would like to know what are the protective foods, because yes, we need a lot of antioxidants and nuts and oilseeds which contains omega-3, which are protective and phytochemicals in metabolic syndrome. So would like to know basically the fruits and vegetable and nuts consumption. Salt and alcoholic. And last, would like to know the number of meals, the food timing, and meal gaps,
and what this pattern was. So in short, you would like to know his general lifestyle, his daily schedule and everything. So from this cue, I come to you, Mr. Aritra. Looking at his liver function parameters, now if you see his liver work, what strikes you in terms of management? Like Anaga has already told you what she like to look further into that, why his liver parameters are like that. And what would your approach be to help him?
Yes, it's very good evening to all of you. There's a very good case presentations, and it's very interesting also what Madhu ma'am said and Dr. Anokha said about that, because what we have seen to the patient, that patient is a sedentary lifestyle patient, he is doing a lot of traveling, and he is a vegetarian patient. And what I've seen the report, where we can see that deranged of the SGOT, SGPT, where we can assume the patient is suffering, there are such kind of a liver functions problem. Though we are not sure about the LFT in detail, about the LFT percentage, the SGPT, SGOT, and also we don't have the report of the fibroscan, that we can't judge the patient is either faulty the NAFLD patients, or the patient is an other hepatic or also the non-alcoholic or alcoholic fatty liver and all. So that should be properly investigated in these cases, number one. And number two is that the patient is suffering from the liver functions problem or the liver problem. In that cases, they had to gain a proper diet which could be helpful for the patient. Number one, that what Dr. Anagha said about that, there is a lot of functional food that patients are included, and also the carbohydrate percentage, because she has rightly mentions about the fructose, because fructose sometimes we can know very well, directly goes to this de novo synthesis pathway and increasing this, the triglycerides and all. Another way, the fructose also helpful for the pathway of the ETP, electron transport system chain, and increases the energy. we have to highlight the much more of energy rather than the triglyceride formation. So in that case, the diet would be a good amount of carbohydrate, which is a mixed platter of the complex and the simple carbohydrate, number one. The protein would be the good part. The protein, though he is a vegetarian, so there's a good for him that we can go for a lot of BCA, branch chain amino acid, that we can go for a lot of good like soya products. There are good type of chena, or there are sprouts and all those things that we can go, though we try to avoid the resistant starch or lentil carbohydrates in overnight, because there's a lot of problematic for the GI trouble and all. And also the fat percentage, we can go have good MCT, medium chain triglyceride, and also the the low saturated fat. We try to restrict this ghee, try to restrict the butter, try to restrict the banaspati and all the saturated fatty acids level. And there are good amount of the the good biological value protein, which is basically the BC, and we try to reduce the aromatic amino acid part, which is predominantly found in the animal part. So there is no questions for the animal part. And also they try to restrict of the the fatty foods from the outside. Don't go for too much of kind of deep fried stuffs and deep fried snacks, because these are much more chances to having all those things. And also nowadays we can go for this optimum nutrition. Very well the chances of the S-adenosine L-methionine, like SAMI. So SAMI is a really helpful things for the methyl donor of the all methylations, and regulate the synthesis of the glutathione, this main cellular antioxidant, which is very important for this patient in that cases, to protect his liver for the further damage.
Yeah. Okay.
So in that case,
so this basically you will try to modify his diet to lower his quality of fats in the form of lower reduced or minimize the trans fats probably that he must be having during his traveling and during his meals. Have a good protein source. And paneer, of course, you said that dairy products is there. But again, when we give a dairy product, we need to know that it is again a low fat one, because something
yes,
like in
the dairy product should be from double toned milk, also
yes,
skim
so
milk, we can
that
paneer,
that
but not
also
for the
point,
full cream paneer.
that pointer has to be
Yes.
we have to give him that this thing also. Okay, so
Yes.
Dr. Geeta, I come to you next. Considering his anthropometry, his weight, and like you can see his waist circumference is high, would you like to counsel him for some weight loss? And if so, what nutrients would you like to focus on? Assuming that he's a pure vegetarian, and the total calories, like the carbs, you would focus more on his calories for him to lose weight, overall calories, and what about the percentage of what carbs would be more reduced, or the fats or the proteins, or would you consider even pharmacological help in this patient?
Thank you very much, Madhu ma'am. Thank you, Chairperson Dr. Anita, to have us here. And thank you, Cheryl and Day team, for inviting me here. Coming back to the case, Dr. Ananda has beautifully explained. Dr. Altra has also highlighted nutrients in the management. But if you look at the practicality of the case, according to me, my primary goal will be looking at how did this all start. It started with weight gain. Overall, the challenge was gluconeogenesis, adipogenesis, where whatever carbohydrate excess energy sources from fat and carbohydrates had nowhere to go. There's no energy expenditure. There were no much muscles to store glycogen, and ended up getting in a lot of visceral fat. So I think primarily we should look at reversing of the obesity, where the n number of areas will be taken care of, because this metabolic syndrome's culprit is obesity.
Yes.
But the challenge with obesity is macro and micro distribution here, because the food is not in his hand. His travel profession doesn't allow him to adhere to the type of food which we would like to give him. Ideally, for this kind of a case, DASH diet, Mediterranean diet, MIND diet have been a lot of given studies and research support to work on a lot of plant proteins, plant-based diet, which helps him. He is definitely vegetarian. But I think let's first look at his appetite and satiety. Generally, when we are traveling, the intake of a lot of processed food, like the breakfast can become cereals, for example, easy to eat. That adds a lot of processed food. There are a lot of sugars which are coming, added sugars coming in his diet through the outside food that can be taken care of. We need to incorporate as much fruits and whole vegetables. The DASH diet concept in his pattern, we can always say that one meal of the day you can replace with fruit and vegetables. I'm saying fruit, one, and vegetables. So this can be a soup, it can be a stir-fry vegetable, because that is the most safest option for me to give him, because I want 40% calories to come from carbohydrates, and that too more of the calories coming from the fiber part. But the fiber need not be always a salad, because he has gastritis, the insoluble fiber, the roughish part, volume based, will be difficult for him to digest. More of soft cooked fiber, it can have a potato, it can have sweet potatoes, the resistant starch which Aritra was talking about. So a kind of a diet which is more of plant based, more of colors can be incorporated. One meal can be completely replaced by that. 2 meals we need to understand, as Dr. Anaga beautifully said, that I need to take his diet, recall his exposure to food, his availability of food, and cut down all the food which is processed in his menu, where he says that I add honey, I add some kind of syrups. All that needs to be cut down. That's primary goal first. And then adjust his appetite and satiety. It's very easy to calculate, because I would calculate 1600 to 1800 kilocalorie. I know there's no energy expenditure. I'll say 40 carbohydrates, 20 fat, 20 proteins, and 30 40 to 50 carbs, and then 30 fats, good fats. All that has been highlighted. But end of the day, his appetite will decide how much he wants to eat. If he has a large appetite, train his appetite first to work on calorie control by having good satiety. Because these people, when they are traveling, they don't really have a very good way of looking at food. The food is comfort, happiness. The food has a lot of other definition than nutrition. And then when you are stuck up with some kind of medical diagnosis, they come to us for help. It can be one-day counseling. It may not be adhered.
Yeah,
so understand the appetite. Try to work on 1800 calorie control through his appetite and satiety training by following a food order, giving a good fat protein first kind of a diet, telling him about the portion controls, and gradually try to make him lose weight, motivate. I think weight loss will definitely, with a good diet plan, will definitely reverse all the symptoms what she's going through this metabolic syndrome. Thank you.
Thank you. Thank you, Dr. Geeta. So now, Shweta, what do you think? Would you like to add something more on what the previous 2 or 3 panelists have said regarding what could have been the cause for his condition, like, from what we could get from his lifestyle? So what could have led to this condition, this pathology in him?
Very good evening to all present. Thank you, Madhu ma'am. Thank you, Anita ma'am and Cheryl ma'am, for giving me this opportunity. Ma'am, as we can see from the slide that this patient is having a BMI of more than 32, HbA1c is also high. We can see the OTPT is on the rise. So all these conditions, they are leading to the metabolic syndrome, along with associated with the hyperuricemia. So this all is associated with metabolic syndrome, and we can see that converse is also true, because of hyperuricemia, the patient must be having the metabolic syndrome. So the condition behind his situation is because he is obese, and his condition maybe it is because of genetic or hormonal. Apart from that, he is having the poor lifestyle disorder and sleep disorder. So it has been seen that abnormality in sleep hemostasis, it is generally associated with increase in the hypothalamic pituitary adrenal axis activity, which generally rises in the circulating levels of stress hormone, that is cortisol. And it has been seen that the stress hormone is actually responsible for the visceral fat. Then we can call that poor dietary habits and lifestyle is always considered to be a secondary.
That is basically the lifestyle, and sleep is generally not considered as a dietary intervention, and people don't realize that their weight gain or whatever problems that metabolic problems they have could be related to say a thing like sleep also. But nowadays that is well recognized and established. So again, I come back to you, Mr. Aritra. What about the patient? He's overweight, of course. He may not have come for that weight alone. Probably it is when he discovered that his blood sugars have risen, and that is when they get the first shock that what he's going to be. He is diabetic or he is pre-diabetic, and probably now he's going to have to stop eating everything and get injections and all that. So basically, generally in my practice also, we see patients really getting worked up when they first discover such high levels in the blood. So as a nutritionist, how would you reassure him of reversing his parameters to normal? Diet and medicine, what would be more important for you?
Yes, this is also again in the context. We have seen the HbA1c 6.5%. So you can see that there is a consensus of the American Diabetes Associations in 2019. They have said about this remissions of diabetes or reversal of diabetes, where till 6.5% they can walk with this remissions of diabetes. There is a chances of the remissions of diabetes. So in that cases, the diet or the therapeutic diet for the remissions would be the best options for the patients, because if he's in pre-diabetes or if there is a history of this C-peptidase and all, then we can see these patients can have good amount of what Dr. Geeta has said about the DASH diet or any other diet where they can good amount of the fruits, good amount of the soluble dietary fiber, good amount of the the complex carbohydrate, and also the fruits in his diet. So that would be the definitely helping for the remissions. But here it's not clear in the picture whether the patient is having any kind of medications. Maybe there are endocrinologists or diabetes starts with the biguanides, metformin. So metformin again is a good role for the weight reductions also, and then they can convert into the insulin secretagogues like sulfonylurea and other drugs also. In that case, there are chances of little.
Mr. Ritra, just in case, if we assume that he has just discovered these values now, and he has not gone to any endocrinologist for that matter, not started on any medicine, and he realizes that there must be something wrong with his diet that nowadays people have to know. So would you try to refer him back to the endocrinologist and say, no, you have to take some medicines also, as you said that it is reversible, and you'll try to reassure him. So how you'll wait for the diet, or you will refer him to endocrinologist if he has not already been to the endocrinologist for medicines?
Look, in that cases, yes. In that cases, the context of your reference of the endocrinologist, because we have seen that he is traveling 15 days in a month. So definitely the rechecking and follow-up is very important, because if the patient is unable, because there is something theoretical can be possible, but practically it's impossible to him, because he is such kind of job, maybe traveling is very important, and he is up to have taking the outside food, because already we have seen he is also suffering from the hyperuricemia, whether we are not sure that he is taking any kind of uric acid drug and all, because nowadays the research been shown that their fructose metabolism is much more crucial than the purine metabolism. So that's why the high fructose corn syrup, the aerated drinks, the alcohol would be the much detrimental rather than the mushur dal and all those things nowadays, the purine and uric acid management. And in that cases also we have because in that if the patient has come to my first, because what I have referred this American Diabetes Association 6.5%, till we can treat with the dietary modifications and also therapeutic diet for the patients, we can try for the remission and reversal. So if the patient is unable to do in that cases in this probingly, then we can talk to the diabetologist or endocrinologist about taking the medications or the insulin, whatever he will decide. But again, the C-peptidase role is a very important, because I hope the patient is suffering from the diabetes or impaired glucose tolerances. So in that cases, according to the patient ease and the patient's practical, if the patient realize that 32 kg per meter square is BMI and fat percentage is higher, so in that cases diabetes would be, and I don't know the patient history, the like genetic history and all, then the patients will automatically will do with the diet. So diet again is the holistic approaches would be our first option. If the patient unable to do, then he can start with the medications and other.
Thank you so much. Anaga, coming to you, considering his raised uric acid levels, now he's a vegetarian, he's a non-alcoholic, and he says that generally it's assumed that uric acid in general public, the lay person also, when he comes to us, he will say, "Main to protein khata nahi hu, I don't have pulses. How did I get uric acid?" Because that is generally associated with proteins, and especially all kinds of proteins, whatever people are aware of. So what would you tell him what the cause of his this high uric acid is, and how will you try to tackle this?
Yeah, so ma'am, you said very, very rightly that generally whenever a patient comes to us with hyperuricemia, on their own, they've stopped the dals.
Yeah.
They stop all the legumes.
Yes.
They stop all the dairy products. And because they read it somewhere on the internet, they stop spinach, they stop basic foods, which are told on the internet that they are rich in purine. So that is something which we come across all the time, and it is very difficult. We have to really work hard and show them evidences to show them that this does not increase the uric acid. So as I said earlier, that after taking the detailed diet history, generally here I would like to say that raised uric acid often coexists with obesity. Yes. Obesity is also linked with having high uric acid levels, and high uric acid level also has shown to in the progression of increasing the progression of metabolic syndrome. So from that point of view, uric acid is also pro-inflammatory and it causes a lot of oxidative stress. So considering all these factors, when a patient comes to you with hyperuricemia, the first target is to take again a good diet history, and the major focus again remains on the carbohydrate, because often excess carbohydrate is one thing. But as Dr. Aritra also said, that excessive intake of fructose is seen very, very commonly in patients. Fructose is also mainly sucrose. So all the sugar-sweetened beverages or the simple sugars, they are, I mean, if this is a corporate guide, but otherwise patients have a lot of, they say, I barely have sugar in my food, but then they have n number of teas. Chai.
And especially non-alcoholic, if he's strict non-alcoholic, and if he is in a meeting and where there's alcohol being served, he probably would resort to juices or soda.
Exactly. Also, or even chai for that matter, or coffee. So there is a lot of access to, and also all the fruits rich in fructose, the confectionaries and everything are quite easily accessible. And the fact that he's traveling, he might just be coming across this and having it and maybe, binging on it. So that's something also we need to rule out. And often it surprises you that they barely eat any dal or legumes, or they barely have those dairy products or even meat for that matter to raise that kind of uric acid level that it should. So what really works is to, achieve a good sustainable 5 to 10% of aim at 5 to 10% of weight loss, because that actually beautifully brings down the uric acid. Not even need to restrict the foods which are rich in purine.
Yeah, basically that is important, because not restricting the weight, the foods that he already has restricted. Bring down the beneficial ones.
Yes, bring down the carbohydrates. Yes, bring down the carbohydrates to at least 50%, 55%. Give good amount of dietary fiber, cut down the fructose, and limit at least in some extent the sucrose, and improve the gut health as well, because that's very, very important. That's something we need to, and incorporate fruits, vegetables, and antioxidants, phytochemicals in order to improve it.
Thank you. Yeah. So that's that being done. We have almost touched upon the dietary intervention on this patient. Now, Shweta, apart from dietary intervention, would you like to advise him on something else to revert to a healthy form which is more sustainable?
Yes, ma'am. As Anaga ma'am has told, that weight reduction is actually very important in this condition. So for weight reduction 5 to 10%, we have to improve his dietary habits, because he's traveling 15 days in a month, so he must be having faulty eating habits. So first of all, we have to correct that. Like, we have to tell him what options he can look for. Like, he can take the food from home if possible. If not, then he can look for the healthy options there. Along with that, not only calorie restriction, but physical exercise is also very important. So
non-dietary intervention basically.
So 30 to 60 minutes of walk. Maybe he can have the pedometer. He can just check out his activity level during the day, during his work. Like, if he was having a lunch break or dinner break, at that time he can go for a walk. So in that way he can increase his activity. And the days when he is at home, he can go for, along with the aerobic exercises, he can go for the resistance training exercises also. So this is the main important thing. Along with that, he has to check that what food options are there when he is out from the home, when he is taking care of the business deals. And along with that, if he's going for some parties, because we are social human beings, we have to go for the parties. What good options we can look for having to treat all these conditions, because diabetes and this uric acid, all these are correlated, and with weight reduction and with healthy eating habits, we can definitely treat.
So basically, we can advise him, counsel him in how to manage by reducing all those foods. So one way would be like, when he has to go for some functions or parties, he can fill himself up, eat something from home before leaving, so that he is not so hungry to really binge upon. So basically, portion control also we would look into, and advise him to, even if he eats those things, there's no option, and how much how frequently he can have those things, because he cannot just shut his mouth. That will not be a sustainable thing. So portion size and the frequency of such foods, which foods are to be totally avoided, and which foods he can have in a social gathering, in what frequency and what portion size. Okay, so that's how we manage this patient. So now coming to you, Dr. Geeta, and I would like to sum up the whole management with you, to you. I would now, how will you, highlight a bit on, we are seeing these increasing numbers of patients with metabolic disorders and the entities involved. These are just a few of the entities we have seen, but there are not many entities involved in this metabolic syndrome. So do you think there's something to do with the eating culture today? And how can we as nutritionists intervene to press up the pause button for this whole scenario that is increasing?
Absolutely, Madhu ma'am. What a wonderful question. Each one of us are responsible for all this because we are the flag bearers of health and wellness and prevention. End of the day, what is important for every patient is in today's era, everybody is well-read, well-known, everything he knows. He comes to us just because he wants some kind of a solution which is doable, maybe a hand-holding, maybe motivation, maybe a friend. So whatever he looks up to us as counselor, we should be there for him to work on whatever challenges he has. To start with how to handle these kind of cases, the challenge is the environment and the trigger of the environment. The environment generally talks about is poor sleep to start with, reduced physical activity. With this, what happens is the trigger is lethargy, tiredness, weakness, and that's a very common symptom of metabolic syndrome, and hence total fatigue doesn't allow him to move much. So step one is make his 3 areas of health very important for any individual: good appetite, good bowel movements, and good sleep. Once these start falling in place, things automatically, mindfully, consciously will start falling in place. The environment triggers are basically the appetite today because of the lot of processed food and the added sugar and the added salt. The quantitative approach to food is really going high. A cold coffee and a hot coffee. A cold coffee, I can have 300 ml. But if I have a hot coffee, I ended up having 150 ml. So the adding of ice cold foods, adding up of added sugars, these are the triggers for my volume eating. I've started putting a lot of calories through the volume of processed food, and that's the area where we want the policies to come in action. Because in India, anything extra is free, and we all are very happy with this free and portioned, extra portion foods. But that's so dangerous and so voluminous, we need to understand, and we need really some forums like this to take up the issue of portions and some kind of a policy decision in quantitative approach of all the processed food. No nutrition label, nobody reads, nobody tries to work on it because it's all happiness when you eat. We all enjoy eating that, and that is why not to eat becomes a big challenge in such questions. Third, nutrients-based nutrition. We are looking at somewhere uric acid or glycemic load of the meal and obesity management. By doing all this, we are adjusting the macros, doing counseling, motivation. From soil to plate, if I look, I am lacking micronutrients. Especially in uric acid, I need to know his B12, folic acid, and B6. So a micronutrient supplementation can be started with the B complex and the D3 can be looked at. So each nutritionist also should aim at looking at the nutrient-based nutrition along with macros, because nutrients are facilitators for all the areas of your energy metabolism, your gut microbiome, your neuroendocrine system. So end of the day, what we're looking is mindfulness. Patient knows this is not right and he should follow it. He knows that he has to exercise, he should exercise. He knows he should sleep well on time. Everything we all know. But the triggers or the facilitators to all this should be the nutrients which we want it to happen. And to conclude, whatever we've been discussing so wonderfully put up by all the panelists, each area, right from screening to nutrient-based nutrition, what we need to put forward as a policy, as a dietitian, as the healthcare providers, is we all need to emphasize portion control, nutrient-based nutrition, holistic approach towards lifestyle, maybe an integrated approach, as very beautifully said, that oxidative stress, inflammatory stress, a lot of stress and metabolic stress together has given all this. Try to look at the root cause of that particular illness. So a holistic approach towards any kind of a medical management, I think, is the answer and way forward. And I'm sure we nutritionists can do it in a big way. So I think we have to gear up to work towards policy making. Thank you very much.
So very well summed up, Dr. Geeta. And I think we come to the end. So overall, we have to look at this kind of a patient who walk into our clinics is portion control of the food, what foods they are eating, basically real food versus processed food, and lifestyle, that includes their sleep pattern, the sleep hygiene, the physical activity, all of these, the choices of foods also, and a balanced and a holistic kind of a lifestyle that, as you mentioned. So this is how we.
Congratulations, Madhu and the team.
Thing.
Excellent.
So
One case presentation, and he's taken half an hour, but he's dwelled on every aspect of it. And really, it needs a lot of hand holding with these patients and teaching, especially once he's traveling. He has to be told how to pick and choose from those elaborate menus in the five-star hotels.
Very
but once we do handhold them, I think we do achieve results. And we've seen a lot of reversal, as you said. I'm so glad I heard that you didn't start him off on medicines at the first go.
Right.
And we've seen very, very good results of reversal and coming back to 6, maybe not 5.5, but at least 6 we can be.